So on behalf of the Better Breathing Institute, I'm Dr. Sabrina Bra, and I would like to thank you all for joining us for our first webinar. The Better Breathing Institute is a dedicated platform for providing education, credible resources, and expert insights on respiratory muscle training. It's supported, although not officially endorsed, by PowerBreathe International Limited. Today, I'm delighted to be joined by an international expert in respiratory muscle training and board-certified cardiovascular and pulmonary clinical specialist, Dr. Rich Severin, who will be discussing the basics of respiratory muscle training and testing. Dr. Rich has just finished a PhD in rehabilitation science at the University of Illinois, Chicago, with a focus on cardiorespiratory physiology and obesity. Alongside his role as a clinical assistant professor and the program coordinator for the UIC UI Health Bariatric Rehabilitation Program, Dr. Rich's research accolades include investigating the effects of inspiratory muscle training for rehabilitation in patients with heart disease, the association between respiratory fatigue, aerobic exercise, and obesity, as well as the impact of COVID-19 on respiratory muscle performance and the benefit of respiratory muscle training. Additionally, he is the author of the section on respiratory muscle testing and training in the 12th edition of the American College of Sports Medicine Guidelines for Exercise Testing and Prescription. So without further ado, I will hand over to Dr. Rich Severin for today's webinar, and there will be an opportunity for questions at the end of the talk.
Right. Fantastic. Well, thank you so much, Sabrina, Dr. Brar, and for everyone attending, logging in from around the world. I've heard we've got people from multiple countries spanning across Europe, and other continents as well too. So excited to present on this. It was a passion of mine as well as an area of interest and research. So I'm happy to share this with you guys, and then hopefully we have some time for some good questions. So let's kind of get started. So some just disclaimers. Of course, I've done webinars for companies, including PowerBreathe themselves. I have different consulting roles, some product testing, and I teach courses for a couple other continuing education groups. So just, I view myself as an equal opportunity person in terms of the testing, but the folks in PowerBreathe are great, and I'm glad for them to invite me here today. Now, this course will be kind of an intro as well to some concepts. However, if you are interested in learning more about respiratory muscle testing and training, I've got a bunch of excellent, at least I think excellent, and I've heard good feedback, resources I post on my YouTube channel. They're open access, they're free, non-monetized, that people currently use. So feel free to check those out too. And then you can reach me on any of these platforms. Twitter or X, I guess we call it X now, Instagram and Facebook. It's all pretty much the same as PhD reviewers. So if you want to reach out to me outside of this course, those are probably the best places to get a hold of me. So course objectives, you probably read them as signing up for this, but we're going to go over the basics of the evaluation procedures for testing the breathing muscles. We'll also cover briefly, and for it's a Saturday morning for us here in stateside, and an afternoon for those across the pond. So I'm not going to dive too deep into the physiology for a Saturday, but we'll cover some kind of basic foundational stuff. And they'll go over how to interpret our data from testing, and then how to implement it into practice. I'll stay on too as well, because I've tried to keep this focus for an international audience. So normally when I give this talk, I talk about specifics for insurance reimbursement, which is very relevant in the States. So if for those who have questions about that, I can answer that. But I wanted to keep this as general for everybody who may not follow our insurance model. So we'll see. I don't know if I'll be able to get responses here, but we usually throw this out to people, just like how often have you, in terms of did you learn how to perform respiratory muscle testing in your entry level training? And I don't think they'll be able to give me responses back, correct? Will they?
Unless I put it as a survey, I can put it in a question, but we might not be able to do that, Rich.
Oh, I think they can raise their hands. Actually, yeah. Show of hands. Did you learn how to perform respiratory muscle function assessment training during your entry level education? You can use the hand raise feature, which is literally how I do this when I give this talk in person. People raise their hands. Okay, a handful there. Not surprising. That's why you're here, right? Okay. And have you incorporated respiratory muscle training into a patient's plan of care? Have you used it clinically? Those numbers are going up a little bit. Okay. I find that interesting that it's not covered as much in entry level programs, but a lot of people find a way to use it, which is good to hear as well. Okay. And personally, have you used respiratory muscle, a trainer, to improve your functional, athletic, or maybe even musical performance? Do you use it yourself? I have a handful there too. All right, so and that's not too surprising. I've given this talk in similar fashions of different across the world actually, but and hopefully by the end of this, everyone will be a lot more comfortable not only assessing clinically, but implementing and maybe even utilizing it. So and as you'll see, some of the concepts are in terms of what you'll need to be able to do or understand to do respiratory muscle training. You're kind of already doing, and maybe in a different fashion. So as you can see, respiratory muscle training really isn't something new. It's been around for quite some time. um, obviously there's been an increase over time, but there's early papers going back to the 70s, so it's been around for some time, and really peaking in popularity recently, especially if we look at in terms of publications following COVID. I think that really reinvigorated some interest in testing and finding ways to improve the performance of the breathing muscles. But um, and again, it's only going to continue to increase. Now, I always find it's interesting too, looking at where do people tend to publish a lot on respiratory muscle testing and training. It's a great study by Ramley et al looking at the geographical distribution of publications. There are some centers of populations where we see the bulk of the publications. So United States, obviously, the United States publishers, I think, in total, the largest amount of research. That's not too surprising. But there are hubs within the UK, in Italy, and particularly in Brazil. They publish some fantastic work on respiratory muscle training, and then Australia and New Zealand, those groupings there publish a lot of it as well. And then there's a group out of the Netherlands, or sorry, and Belgium that published the Leuven, I believe, in Belgium, publish a good bit of work there. So in terms of if you're looking to find future publications, those are some centers really of excellence in terms of where we see a lot of really good work in respiratory muscle testing and training. So, like I mentioned, we're going to cover a little bit of physiology. We're not going to spend, a ton of time on this because I don't want to bore you to death here. But it's important to understand what's actually going on in terms of when we're testing the breathing muscle. So a couple of things to unpack. And we use this kind of interchangeably in the field of physiology, as well as in physical therapy and rehabilitation, like breathing, ventilation, and respiration. We kind of use them, all as the same sort of term. They are actually slightly different concepts, which should be so surprised for many of those on this call. But breathing is kind of a more general sense, both includes ventilation and respiration. However, ventilation really relates to the movement of air in and out of the lungs. We're talking about flow rates and volumes. Versus respiration, we're really talking about the exchange of gas across the alveolar capillary interface. So really the breathing muscles, even though we call them respiratory muscles, are really more ventilatory muscles. But you'll hear me use it interchangeably here too. But just letting you know when we're talking about these muscles, we're really talking about again the movement of air across the in and out of the lungs, not so much exchange of gases. And obviously, control of breathing. We've got a multitude of inputs that go into regulating breathing, though it is, again, under conscious or unconscious control, kind of contracting rhythmically and intermittently throughout life. We have multiple inputs that allow us to match breathing to the demands of the activity or the physiological state our body is within. The other cool thing is too, we have a very tight kind of linkage or a tight coordination of breathing with movement and exercise. And we'll talk a little about some of the changes that occur with exercise, which will help explain why impairments of performance of the breathing muscles can impact exercise. And then we have, again, of course, getting these multiple receptors, that peripheral chemoreceptors, mechanoreceptors in the lungs themselves. So if we breathe in, we breathe in very deeply, we actually suppress the drive to breathe just to prevent hyperinflation. We also have mechanoreceptors and metaboreceptors within the muscles, which help accentuate the drive to breathe. So again, we're really good. Kind of the main thing to take away from this is that we're really good at matching the demands of breathing or the physiological state to breathing. We're really good at keeping that in balance. But however, there are some situations where that can change. And one of those situations where we lack the ability to match is when we have impairments in performance of those breathing muscles. So again, quick review of the anatomy. The muscles of the ventilatory pump, again, they contract rhythmically and intermittently throughout life from your very first breath to your very last breath. And in fact, we actually find spontaneous activity in the respiratory central pattern generators in the brain, like our areas that kind of control that rhythmic pattern of breathing, even before we have to use them in utero. So we're really good and really hardwired in keeping our breathing, efficient. Again, they operate under primarily involuntary control. We don't have to think about breathing, but we do have some opportunities and some ability um, to voluntarily increase or decrease both the rate and depth of breathing. So we all can take faster breaths, slower breaths as well too. So we have some voluntary control. And the muscles of breathing primarily work against airway resistance, so the caliper size of the airways, and then elastic recoil forces, the lung chest wall complex. Fortunately for us, though, those demands of breathing are generally pretty low. If we look at in terms of what we need to be able to produce to generate a normal breath, we're talking like 5 to 10 centimeters of water to bring in a normal tidal volume. And typically, we produce about 100 centimeters of water, give or take. We'll talk about norms in a bit of maximal pressure. So we operate under a very high degree of efficiency for breathing. So we're really, really good, not only again keeping things controlled, but we operate at a very high degree of efficiency of breathing. Um, Now, inspiration primarily going to be done by the diaphragm, 75 to 80% of the inspiratory effort at rest. Now, again, that's a little bit, again, different during exercise. We'll get into that in a little bit. And we also have contributions from the quote unquote, and I put this in quotes because maybe we'll have a discussion about this too. The accessory muscles of breathing, your scalene muscles, your sternocleidomastoid, your pec minor, anything that really attaches to the ribcage. I put that in quotes because those muscles really, I think that's a bit of a misnomer of a term because those muscles are always to some degree electrically active. We look at EMG recordings, of the breathing muscles, those accessory muscles. They are active and actually they're really important for maintaining that normal pattern of breathing, kind of the upward displacement of the chest wall. And obviously, if we have too much activity, that's not a great thing. It reflects weakness of the diaphragm, but so to say that all of these muscles have, play a role to some degree of breathing. And again, like I think labeling them accessory is a little bit of a misnomer because they are kind of important too, even under resting conditions. Expiration under resting conditions, it's primarily passive from the elastic recoil, the elastin proteins within the lungs and the chest wall. So we don't really spend focusing our energy during expiration at rest. It's primarily passive. That, of course, changes under resting conditions. During exercise conditions, where we're having forced maneuvers, as well as during coughing. That's also going to require some forced muscle contraction. That's going to come primarily from the abdominal muscles and the intercostals. So again, just a little bit of a review there. And again, just looking at how these muscles kind of work. And again, just remembering that there are, more muscles involved in breathing than just the diaphragm. I know it gets a lot of the focus because it is the big player there, kind of the end effector in a certain sense of the respiratory CPG. But we have, again, the intercostals, the sternocleidomastoid, the parasternal muscles, all play a role to some degree. Scalene as well, sternocleidomastoid. So again, just and especially as we begin to exercise, we start seeing greater recruitment of those quote unquote accessory muscles. And even the role of the diaphragm, the role of those quote unquote accessory muscles does begin to change a little bit. So Here's a great paper. Alberti in Breathe, which is one of the European Respiratory Society journals. It's an open access journal. It's actually a great paper that I recommend everyone reading if they're interested in learning a little bit more about the science of the breathing muscles. It talks about the change in roles of the breathing muscles. So during exercise, sorry, we'll start at rest. The diaphragm, the rib cage muscles, which again are those, we'll think of those quote unquote accessory muscles, are both pressure generators. So they're going to be the primarily contributor to changing that pressure differential that allows air to flow in and out of the lungs. Abdominal muscles are going to be generally inactive, like we mentioned, expiration, primarily passive. We only start seeing abdominal muscle activity during forced maneuvers, like during exercise and with coughing. However, during exercise, this changes to a degree, and the diaphragm's role becomes more of a flow generator. This means that its mechanical power is mainly expressed as a velocity of shortening rather than pressure. And again, the rib cage muscles and the abdominal muscles are primarily pressure generators. They develop, again, those pressures required to move the rib cage and abdomen, like respectively. So again, during exercise, because of the forced maneuvers, we start seeing abdominal muscle contributions kick in to help quickly move volume out so we can get volume in the subsequent breath. But again, all of this is trying to illustrate that we often view breathing, especially inspiration, hyper focus on the diaphragm, while often forget and labeling these other muscles accessories, kind of a vestigial. They are actually very important, and then especially during exercise they become increasingly important, and their activity normally increases because again the diaphragm has a slightly different role as a flow generator versus a pressure generator, again during exercise. So just a little bit of a caveat there, and I think it's something that a lot of people often aren't aware of. And then looking at coordination of breathing with exercise, again, just like at rest, breathing is tightly controlled. This is also another fantastic paper by Foster Dempsey, two legends in the field of respiratory physiology, looking at the changes that occur. We think as well like some feedback processes from those mechanoreceptors and metaboreceptors in the periphery, even in the muscles. We also find there may be some feed forward activity, in fact, that that helps kind of prime our ability to exercise. So if you even know you're about to exercise, or even having an individual like sit on like a cycle bike, an exercise bike, we find that will typically result in like an increase in heart rate and ventilation rate to prevent, we think, like a lag in matching breathing. So again, like we are very good at keeping breathing coordinated, and there is a typical pattern that we should see as someone begins to breathe. So at the onset of exercise, we should see a rapid increase in tidal volume, excuse me, where the increases in breathing frequency are a little bit more modest until about 40 to 60% of maximal exercise, when it begins to rise more rapidly. And we'll kind of show what that looks like graphically. And then we'll also talk about kind of probably why that happens to a degree. There's some pretty important, like, I guess, biophysical reasons for why that's important. So this is kind of what we're talking about here. If you look at, again, at the onset of exercise, so this is a plot of someone exercising to maximum effort. We look at rest on the bottom left, maximum effort on the bottom right, and then we have different plots for different things, of course, looking here. So the main takeaway, let me get my little pen, is again that at the beginning of exercise, so VT corresponds to tidal volume, and then FB corresponds to frequency of breathing, and then VE corresponds to ventilation, and VA alveolar ventilation. And as we see during the first, again, stages of exercise, we start seeing tidal volume increase, okay, a little bit more dramatically than our frequency of breathing. And then right around 40 to 50% of someone's maximum effort, we start to see frequency of breathing kick up a little bit, and then tidal volume begins to plateau. And we'll kind of talk about like why that occurs in a little bit. And this happens really to do with this concept of dead space ventilation to alveolar ventilation, right? So again, remember, while we're talking about ventilation here, moving of air in and out of the lungs, the goal of breathing ultimately is to maintain appropriate alveolar ventilation, the air moving in and out of the alveoli, to support respiration, adequate gas exchange, right, to fuel all the aerobic metabolism going on in the body, as well as to move metabolic waste of CO2 out of the body. Um, so ventilation corresponds to, again, the volume that we're moving over a unit of time per minute, so in liters per minute. And we get that by calculating the tidal volume, VT, which is a volume, and the frequency of breathing, which is the breaths per minute, okay? Um, Now, in a young, healthy individual, dead space ventilation, dead space volume is relatively small, right? And it's a fixed kind of anatomical area or volume, which corresponds to about 150 milliliters, right? So our dead space volume, okay, is about 150, okay? And dead space ventilation begins to increase, okay, as frequency of breathing. We'll kind of show you what that means here in a little bit, okay? So, and alveolar ventilation, again, the ventilation that's actually getting into the alveoli is calculated by our VE minus our dead space ventilation. And I'll show you kind of what this sort of means in a little bit here. So if we look at two plots here and kind of what this is trying to illustrate, and why breathing and having strong muscles can generate large volumes and move large volumes in and out of the lungs, it all corresponds to this. Okay, so VE during exercise here, right? We've got two different patterns. Both move the same amount of volume, okay, in and out of the lungs over the course of a minute, but they both accomplish it slightly different ways. So in pattern A, okay, they have their tidal volume during exercise, okay, is 1 liter. And again, dead space ventilation is a fixed anatomical volume of 0.15 liters or 150 milliliters, okay? All right, their frequency of breathing is 40, okay? And like we mentioned, dead space ventilation corresponds to the anatomical volume times the frequency of breathing, okay? So their dead space ventilation, okay, is 6 liters a minute. And we mentioned alveolar ventilation corresponds to VE, the volume that you're breathing in, in and out of the lungs, minus that dead space. So it would take 40 minus 6, okay, 40, again, the VE, ventilation, and then minus 6. So that would give us an alveolar ventilation of 34. Okay, six of those 40 liters aren't actually getting down into the alveoli. Whereas in pattern B, okay, they also are moving in 40 liters per minute, but they're doing that a slightly different pattern. Instead of breathing at 1 liter, okay, their tidal volumes are 2 liters, okay, and they're breathing at a frequency of 20 breaths per minute, okay? And again, because anatomical, or dead space ventilation is that fixed value, their dead space ventilation thus is 3 liters per minute, okay? Because we do 20 times 0.15 gives us a dead space ventilation of 3. And therefore, their alveolar ventilation, which again, if we subtract, sorry, actually, I did this wrong, but if we subtract 40 minus 3, it gives us our 37. So the real takeaway here is if we breathe at a faster rate without increasing volume, it increases dead space and decreases alveolar ventilation. So that ability to take a bigger breath at the onset of exercise allows us to breathe more efficiently and more effectively. So again, big takeaways here, looking at our equations, dead space ventilation is a fixed volume, and that dead space ventilation rate, right, increases as frequency increases. But if we take a bigger breath, we can actually have a more efficient pattern of breathing. We often talk about like patterns of breathing and what's actually relevant. This is kind of what we're talking about here. So if we're able to take bigger breaths, it keeps ventilation more efficient. So again, just remembering our differences here. So again, why that matters, as well as too, not only does it affect the efficiency of breathing, in terms of the volume getting to the alveolus, it also, as we breathe faster, it increases the work of breathing as well as a resistive component of breathing, because it increases the turbulence in the airways. So, making the ability to take a bigger breath during those initial phases of exercise and saving, you know, faster rates so when we actually need them is really important for our ability to exercise. And in patients who may lack that ability to generate enough pressure and generate enough volume, this may explain why a lot of patients will may struggle with exercise tolerance. Again, just looking at our different roles here. Another thing to consider as well is looking at our respiratory muscle metaboreflex. So this is something that we often see primarily in patients with clinical conditions, heart failure, COPD. Essentially, what happens is when you have fatiguing contractions of the breathing muscles, and notably and classically studied looking at the diaphragm, we have a global sympathetic discharge, right? Which causes a global vasoconstriction. And because those fatiguing contractions, which can stimulate this type of afferents, are also vasoactive, they cause relative vasodilation in the vascular beds of those breathing muscles. So what effect happens is you have vasoconstriction globally from that sympathetic discharge from those fatiguing contractions. And then you have relative vasodilation in those breathing muscles. Pressure goes from high to low. We have shunting of blood to the breathing muscles. That's great because it helps us preserve, breathing at the expense of other limbs. Breathing is obviously way more important than, exercise. You need to be able to breathe to live. But what that can cause is early fatigue, especially somebody with baseline weakness who may, not be able to tolerate the increases in the work of breathing during exercise, and this reflex is discharged and causes leg fatigue. So another thing we often look for patients with respiratory muscle performance impairments, we often think of dyspnea and breathing, but they also may report this like leg cramping or fatigue, and this is the reflex that is kind of responsible for this respiratory muscle metaboreflex. And again, generally in healthy individuals, this isn't elicited into supra maximal intensities of exercise, but it can be triggered again in people with baseline weakness. Again, or patients with abnormal work of breathing, even at rest. Again, thinking of patients with heart failure, COPD, and other chronic conditions, obesity as well too. Because again, our breathing muscles operate at a very high degree of efficiency. Again, the work of breathing, even under exercising conditions, is usually far below our force generating capacity. We work at a very high degree of efficiency or economy. However, if the work of breathing either increases or the force generating capacity of the breathing muscles decreases, if these two values approximate, you are more likely to experience dyspnea, right? So again, normally, we have a high degree of reserve. However, there can be situations where either the work the breathing muscles are imposed upon or their ability to produce force changes. We can have some problems here resulting in dyspnea. So again, dyspnea again associated with increased, perceived respiratory effort, and again we talked about looking at how that force imbalance can contribute to it. So clinical implications. I'll get into kind of the fun stuff, getting out of the physiology here. Okay. All right. So now, a question people often ask me is like, what are some populations that could benefit from respiratory muscle training? And I'll hear a lot of people say, well, like COPD, obviously, heart failure, obviously, spinal cord injury, different neurological conditions, obesity. Really, the way I view it and the way we kind of we're moving in practice, at least stateside, is looking at managing the rehabilitation care for patients kind of independent of disease. And I think respiratory muscle training kind of aligns well with that. It's because there are some populations where these impairments are more common, but it's really any patient with respiratory muscle weakness that may benefit from obviously testing to confirm that that's present, and and those with weakness, training. So again, there are some popular ones there, but it's really any patient, either at risk for demonstrating respiratory muscle weakness. Again, there are some populations where they have a higher risk just from the pathological processes underway, or patients reporting dyspnea with exercise or at rest, and decreased exercise tolerance or activity. Now, there can be a multitude of things that cause someone to have shortness of breath, or decreased exercise capacity or tolerance. A lot of them. This speaks to the value of testing the breathing muscles to confirm whether or not that is actually the culprit. Because you could possibly be missing something and leading someone down a pathway of treatment they don't really need. So, something we often see a lot in clinical practice are people like prescribe respiratory muscle training without testing. Now, probably not going to harm the patient in that scenario, but you may not be identifying if that's actually the impairment contributing to their symptoms. And then it may be harder for you to establish that initial prescription appropriately for that patient. So we'll talk about like why it's super important for testing as well, in clinical practice and in research as well too. So you may be wondering, because there's a lot of maybe some mystery, or information that may not be super new to, or maybe super new to people or unfamiliar with, and you may be stuck with this feeling, kind of like Big Bird here, followed behind my favorite character in cinema, Darth Vader. An imposter syndrome. I'd be asking like, can I do this? I'm not sure. We're talking about different things here. He's talking about flow rates and pressure changes, and dead space ventilation. Let's break it down here. There are some necessary foundational skills. And I'll ask you this, okay? You guys can use the hand raise feature here if you'd like. Have you tested muscle strength before? Let's ask you, have you tested muscle strength before? Hopefully all 90 people put their hands up, especially if you're a PT or a respiratory therapist or anyone in rehab. All right, so the majority really of people have. Okay. Have you prescribed muscle strengthening exercises before? Let's see our hands there. Yeah, the vast majority of people here. Okay. Great. Are you able to follow testing protocols? I think the majority of people can follow instructions, right? Okay. And are you able to give patients instructions? Hopefully everyone's able to do that, right? So, congrats. You can do this, right? So, again, I mean, you'll see this as we talk about some of the testing principles and training principles for the breathing muscles. It's the same exact sort of things that we do for any muscle in terms of testing. And then we use very similar concepts for training. And so, again, like it's not too dissimilar from what you may do in your everyday practice. Now, we may use some slightly different terms, slightly different units, but the same general principles are exactly the same. And the way I often view it, and maybe some here are not PTs in particular, but PT is still PT. Okay. You can do this. Don't practice outside of your competence zone, right? Not the same your comfort zone. You can be very comfortable with things you're not very competent at, but this is the same thing, stuff you've been doing. Don't overthink it. Respiratory muscle testing and training, it's really not that complicated. All you're doing is testing for muscle weakness and prescribing muscle strengthening or muscle endurance training. We'll talk a little bit about endurance. We're just going to focus primarily on strengthening exercises. Again, you're developing your hypothesis. If you're thinking a patient with dyspnea, the contributors to their dyspnea is respiratory muscle testing. You're going to test that, determine if that's present. If it is, you're going to, you're compared to normative data to support your hypothesis, and then you know what to treat. It's the same exact thing that you do for a patient maybe with like suspected wet leg weakness. The patient says maybe hypothetically they can't get out of a chair. We're going to test the strength in their legs. If you test them, the results either support or refute your hypothesis, and then now you know what to treat. The same exact principles that we use for any other muscle, we use for the breathing muscles too. Now, there are some guiding documents that I would highly recommend downloading and accessing. There's a great ERS statement on respiratory muscle testing and at rest and during exercise by Levanzina and Verges, and a whole group of them as well too. It's open access. We reference it in this talk. And then there's a great new publication by some researchers, I believe I think they're in Spain, Germany, I think Brazil as well, the group primarily. Fantastic paper. I like their normative data in here. We reference the equations they use because they factor in BMI. And we'll talk about that too, because BMI actually can pseudo-normalize maximum inspiratory muscle strength from the adaptations that occur at rest. So this is one of the few that actually incorporates that, which is very relevant for patients if you're working in an obesity population, patients with dysphagia in that population. So I highly recommend both of these papers, and I believe they're both at open access. Certainly the guidelines here are open access. All right, so we'll get into some testing principles here. So that's what we're going to focus on primarily today are assessments of peak respiratory muscle strength. Okay. And in respiratory physiology and in medicine, we're not very creative. What we say is exactly what we're doing, right? So we've got two general tests of peak strength. Maximum inspiratory pressure, which is the maximum negative pressure someone can generate during a maximal breath in. So the patient starts fully expired, they completely empty their lungs, and then they maximally breathe in, and we're assessing the peak negative pressure occurring over the first 1 or 2 seconds of effort. We're hoping for at least a 2-second plateau. Maximum expiratory pressure is exactly the same thing, but the opposite. So the patient starts fully inflated, and then they breathe out maximally, and we're measuring the peak positive pressure someone can generate again over that first second of effort, hopefully getting a 2-second plateau of effort at some point. Okay. Now, we're going to do 3 trials, just like we do with everything. Okay. Values should be within 10%, just like we do with everything. Now, it's not uncommon, and I always tell people when I teach them this, that patients, the first trial and the second and third trials, maybe, especially compared to the first, may be a bit different. This is a heavily technique and effort dependent or driven test. So it takes some familiarization with patients. I often give them a little bit of practice just without the device, just kind of get the maneuver down, because you typically don't breathe like that. So it takes a little bit of familiarity. So for that reason, the ERS and the ATS also recommends you can do more than 3 trials to make sure that your values are within, again, 10% of each other. They'd recommend not doing more than 9 because you start seeing fatigue, occur, and that will bias your results, right? Because again, you can think of these tests essentially as the 1 rep max of the breathing muscles. It's also important to note that these muscles, again, these tests don't just test the diaphragm, like we mentioned before. These are forced maneuvers. So it is also going to incorporate other muscles as well to breathing, just like they do under forced maneuvers at any point. And then while the ERS recommends 9, a cap at 9, anecdotally, as a clinician and person who does this every day, I actually start often seeing patient performance start to suffer after the 8th rep. So just kind of be mindful of that. Now, testing considerations, okay? You want the patient seated in a chair with their back supported. That's really mainly for safety as well, and standardized procedures. You want their nose clip because you essentially want to create a hermetic seal between the mouthpiece and the patient's respiratory system. So if their noses are unclipped, you're going to lose pressure out or in depending on the maneuver, and that's going to affect your results. You want to keep everything as a closed system. You also want to avoid their cheeks from sucking in like this, because we want to assess the pressure produced here, right, from the muscles attached kind of to the rib cage, not the muscles here, which will give us mouth pressure. Now, What helps with that is using a tapered mouthpiece. Those come out of the box in the Power Breathe devices. But if you're using filters or different mouthpieces, just making sure they use a tapered mouthpiece. Cylindrical mouthpieces you can work, but you're more likely to get the cheek sucking in that situation. And then you want to compare your results to normative data to see how they actually stack up if there is actually weakness present. Now there are great values, normative values produced again in that guideline paper published a few years ago, matched to biological sex and age. Again, most people should generate roughly around 100 centimeters of water. And again, remembering the demands of breathing at rest are like 5 to 10, typically centimeters of water. So we're pretty efficient. And even during exercise, maximum recruitment of the lungs, we're typically looking at 55 centimeters of water. So it's not uncommon for some people maybe to just be below even the lower limits of normal, but still do okay because we only start getting really particularly concerned if they go below their threshold for weakness, again, which is going to generally be, and there's a lot of debate on what the actual threshold is. Most people say it's usually right around less than 60. And again, that corresponds to that, that the maximum, the pressure needed to fully recruit the lungs, which we say is about 55 centimeters of water. So if you can't produce that, or if your max is very close to that, you're going to have some problems, especially during exercise and even during forced maneuvers. And we have some normative data here as well, matched to biological sex and age. Again, we have values there. I would also recommend, again, I love this great paper. It came out by Lista Paz in 2023, looking at normative data factoring in BMI, because BMI, again, tends to pseudo-normalize values because of the demands of breathing at rest. Just like we see in the peripheral muscles, their absolute strength is typically pretty good. But when we can normalize it to body weight, they actually appear a bit weaker. And we actually see very similar things in the obese population as well. Now, there are contraindications. They're pretty much the same as you would see for any form of exercise contraindication. Obviously, someone with hypertensive crisis or an aneurysm or infarction, typical stuff. There are some unique things that we'll talk about, particularly for the breathing muscles. Really, we say any recent like thoracic surgery or injury to the abdomen kind of contraindicate. Now, this gets pushed up. Some people would say typically 6 to 8 weeks. I've seen some studies doing within 4, some within 2 weeks. So always kind of temper your actions with wisdom there. The other big thing, or is really anything related to the eyes, sinuses, the eyes in particular, because if you've got retinopathy, glaucoma, or cataracts, during this maneuver, you have a little bit of strain. So if you have issues with ocular pressure or ocular health, that can be a bit of a problem there. So that's a bit of a contraindication there. Anything really involving the eyes, and then really all usual contraindications. Now, not going to cover this in today, but if you'd ever like to, I have a nice little video. Apologies for the hair; it's COVID hair. Couldn't get a haircut. Going over performing peak strength assessments using the Power Breathe KH2 device here as well. Now, there are also some additional tests that you can consider as well. Again, the breathing muscles are kind of supra endurance muscles. They start working involuntarily from the very first breath you take to the very last breath you take. And we often assess them looking at peak strength, which is good. A lot of clinical data that points to MIP and MAP being very relevant and meaningful clinical outcomes. However, the construct of those tests doesn't really reflect the demands of those muscles because you hopefully never breathe at your maximum. And we're not really assessing endurance for a muscle that's a super endurance muscle. It's like taking a marathon runner and assessing their 1 rep max squat. It's going to give us data, but is it going to accurately reflect what those muscles actually do? So there are tests that look at endurance. You would first establish an MIP by testing and have them breathe into fatigue roughly at 50% of their MIP at a set pace until fatigue. We also have some tests that look at peak work capacity. An example of that, the tire, which still provides the MIP, but also gives some other values as well. And then the sniff pressure. So if you have patients who lose malfunction, if they have Bell's palsy or some sort of dysphagia issue, you can insert a nasal probe with some particular devices that will allow you to measure pressure generated from a maximum sniff, which you can use to assess the performance of the breathing muscles. Excuse me. And again, I have it on here because it's my favorite test, the tire. It's the same exact setup as the MIP maneuver, where the patient starts fully expired and then they breathe in maximally. So we still get our MIP value, but we continue to measure all the way until they can no longer generate flow and thus pressure. So we get a surrogate measure of endurance and time. We also get the area under the curve of pressure plotted over time because we're continuously recording. So it gives us a value of work. And then we also get the slope of that curve, which gives us an index of fatigability. I like this test because it often gives us an insight to some patients who may, again, have normal MIPS, but fatigue very quickly. Again, obesity being a population where we see that pretty frequently. So now we'll get into training. And again, this stuff is not too dissimilar from what you're probably already doing in clinical practice for other muscles. Okay. Now, we have two general types of training for the breathing muscles. We have endurance protocols and strength based protocols. And as you can expect, they follow, again, very similar patterns that we would use to improve muscle strength and muscle endurance. For muscle strength protocols, we're typically going to train at a high intensity or high load at a very relatively low volume. Okay. So typically we're going to start around 50 to 60% of MIP, relatively high volume, again, not too dissimilar from like 50 to 60% of when they're at max for strength training in the peripheral muscles. And we're going to train roughly at 30 breaths per session done twice per day. Not too dissimilar from doing 3 sets of 10 at 50 to 60% of when we're at max to improve strength in the periphery. Endurance protocols, if I want to improve muscle endurance, just like we do in the peripheral muscles, I want to train at a low load or low resistance at a higher volume. Typically 5 to 10 minutes. We're going for time because we're trying to get a large volume to improve endurance. Now, these are general starting protocols. There's a ton of different options out there you may see published in the literature. You can adjust these as necessary too. Like some patients just may not tolerate 50% of MIP. They may fatigue very quickly. So you can adjust your training resistance. You don't have to always use 50%. If they can't get by at 40%, maybe you can go even lower, right? So again, these are good starting points, and you can make adjustments as you would typically in clinical practice. Now, the reported benefits of respiratory muscle training are obviously we're going to improve the performance of the breathing muscles themselves, reduce dyspnea, and improve exercise capacity. It's kind of like I'd say like the 1A, in terms of benefits of been shown consistently in the literature. And the great thing about this form of training, it doesn't take a lot of time. Again, look at our general protocols. It's going to take 3 to 5 minutes per session for a very meaningful improvement in performance and dyspnea. Again, we often take breathing for granted because we breathe at a very high degree of efficiency. It's never really a problem for us, even during exercise. However, in some patients, this becomes a problem. And if you can give someone a tool that they do seated, right? They don't have to get up, go anywhere, that will address a meaningful symptom or impairment to their quality of life, that's powerful, right? And again, like it's very, very simple and very, very, very impactful for these three main things. We are also seeing some research as well looking at improved sleep quality with a paper coming out soon as well, and improved blood pressure. It's a great group out of Colorado. Daniel Craig had looking at this, looking at how respiratory muscle training may improve blood pressure and vascular function. So again, these are the three main takeaways that we'll often see improvements in with training, but there are a lot of other secondary outcomes that we're seeing improve as well. Now, for establishing the initial prescription, like I mentioned, typically we're going to start at 50% of MIP for strength-based protocols, just kind of walk you through how I go about it often in clinical practice. And then I'll test my initial prescription for 10 reps, see how they feel. Do they have, what's their RPE? Are they, beyond a 3 out of 10 fatigue after that first 10 reps? Because my goal is to get them to like 5 to 10, right? Like after 30 reps, right? I want them fatigued at 30. I don't want them super fatigued at 10. So if they're very fatigued, I'm going to maybe drop the resistance down and then reassess. Okay. I'm also measuring heart rate, SpO2, making sure they're not desaturating during training. We'll give them a rest for a couple of minutes. I'll repeat that 20 reps, assess tolerance, same thing, aiming for fatigue after that 30th total repetition. So training considerations. I always think about this with my patients, Bob, great guy. But uh, make sure your patients don't hyperventilate during training. Sometimes patients just can't get the idea of taking slow breaths in against the resistance. So you might need to have them use a metronome and pace them during breathing, so you can have them set a metronome and maybe 15 breaths per minute, or however you want to break it down. Or have them follow a cadence, 3 seconds in, 3 seconds out, because you don't want them to hyperventilate. Again, like I mentioned, our goal is typically 30 breaths for a strength-based protocol, but maybe they just can't, even if you adjust the resistance, they just can't do more than 10. Well, you can break it up. You can do 3 sets of 10. You could do 5 sets of 6. However you want to break it down, to give them rest in between so they can complete their session. And then really encouraging patients to take big breaths, expand the chest and the abdomen, relax the jaw muscles. We don't want these muscles working too much. We want the muscles here working a lot here, right? So again, reduction of that mouth contribution, really getting the muscles from the abdomen and the chest. Now, in terms of training progression, most protocols, are around 8 weeks in length with retesting done every 2 weeks. I say the breathing muscles are kind of like quicksilver. They are highly vascularized muscles, which is not surprising. And because of their high degree of vascularity, they have a high potential for adaptation. So like again, for example, when patients on a ventilator, they get really weak really fast. They actually faster than the limb muscles, but they respond to training much faster than limb muscles too. So again, adaptations both positive and negatively, both in a very fast direction. So it's not surprising to see improvements in strength after even 4 weeks of training. And in fact, I've seen some improvements and published within like 1 to 2 weeks of training. So it's not uncommon again for improvements. That's why you always want to kind of reassess every couple of weeks just to make sure that your training load is staying at an adequate intensity to impose demands. And the other thing is, the value of testing to make sure your prescription is specific. The patients who will benefit the most from respiratory muscle training are those with baseline weakness. It's a true, just like we see in the peripheral muscles. Patients with weakness, in the legs or arms, chest, or so have you, those patients then see the greatest magnitude of improvement compared to someone who's maybe has a more chronic exposure to exercise training. So again, same is true here. Again, which stresses the importance of actually determining if someone has weakness or not, if this is actually going to make a meaningful adaptation or improvement. A question I often get asked as well. So if I do this, do I have to do this forever? Now, kind of depends. Now, there was actually a paper that looked at this to see how long do these benefits last if someone just stops training. We do gradually see a decline in breathing performance after training if someone does not perform maintenance training or participate in vigorous aerobic exercise. Because if you breathe, especially as you get close to higher ventilations or even close to the ventilatory threshold, you will preserve respiratory muscle performance. So the way I often view training is it's a bridge from patients to get to a degree of or get to a point where they can actually exercise to keep those muscles strong and fit. Some patients aren't, so they have to do maintenance training as well. But generally, for most patients, I try to view it as a bridge. Let's get your dyspnea under control. Let's get you to a point where you can actually exercise and maintain the strength of your breathing muscles. So again, if you want to know, there are declines in performance. It's like any muscle. Now, monitoring considerations, clinic-based, I actually say, and this is really coming from the States where we've got not the best coverage for insurance for rehabilitation, but however, though, I do say there is some degree of limited feasibility in clinical practice because most studies utilize training 5 to 7 days per week. It's like a daily thing done twice daily. And it's such a short period of time that I think it's best suited as a home-based intervention because a patient can do this at home. It's pretty safe to do and pretty simple to follow. Now, it may be good to kind of maybe do one day if they're coming to see you routinely, just make sure that their technique is good, that they are like following through and tracking their tracking sheets like that. But I find it the most effective as a home-based program that you give the patients to do on their own at home, and then they work with you whatever they stuff they can't do at home in the clinic. Um, and then telehealth is actually a pretty safe and feasible option, even looked at in patients with COVID. That is it's a very effective way of delivering if you wanted to monitor patients at home as well too. And then again, so we've covered a lot. We'll have some time for questions here at the end, but just remember, PT is still PT, rehab is still rehab. Don't overthink it. You can definitely do this stuff, right? You do this stuff every day. The principles of testing, the principles of training are exactly the same as you would for any other muscle. Again, we use slightly different terms, right? MIP and MEP compared to 1 rep max, right? For the peripheral muscles. We use centimeters of water instead of pounds, but the same concepts here, right? So again, you can do this, right? And hopefully, again, taking this information, you can implement this into your practice to benefit your patients. So with that, I'll end here. We have some references there for you guys, and then open it up. Thank you so much. And I do want to apologize. I think I circled the wrong 40 on the slide covering dead space ventilation, but reference the equation to see kind of what I was talking about in terms of subtracting the two.
Thank you, Rich. I think we'll let you off because that was a nice overview and recap of physiology at possibly 9 a.m. for some people. And I thought that was incredibly insightful and informative. And hopefully everybody now feels empowered to go away and utilize RMT in their daily practice. So if anybody has any questions, they can put them in the Q&A. We have had one. I just wanted to start by asking, in terms of barriers to introducing respiratory muscle training in a rehabilitation program, you
Yeah.
obviously mentioned it, and it will be a little bit country dependent. So in the States, we've got insurance and things like that. Are there any other barriers that you can think of? Are there any resistances that you see from patients themselves, or is it to do with education of the clinicians? Um,
Surprising. I don't know if there's been published work on this, so I'll have to speak anecdotally on this in terms of barriers. One of the biggest barrier to implementation is just lack of knowledge. A lot of people don't know. From a patient's perspective, I rarely do because I'm usually prescribing this in patients with dyspnea or exercise intolerance,
mhm.
who I've demonstrated weakness. We communicate with that to them, and then the I hate to use like the magic bullet kind of approach to things, but this is really effective for patients with dyspnea. And again, thinking of how meaningful dyspnea is to someone's lived experience, you get short of breath. Again, like you start like if we all can hopefully normally breathe that from birth through life, and if that gets taken away from you, and basic things like brushing your teeth, cooking, walking, right? It's become very challenging because you lose your ability to breathe comfortably. If you give someone something that is effective, and typically we're going to see benefits pretty quickly, they're kind of bought in.
Mm.
So I really have not found a ton of resistance from patients just because of again how low of a hanging fruit. It's really short. It's like a couple minutes twice per day to take away a very meaningful negative part of their life, right? Or a thing that really negatively impacts their life. Um, Now, I mean, there is always the situation where patients maybe just don't do it. Like that can happen. But patients who do, like the buy-in is pretty quick because again, of how meaningful dyspnea can be to someone's life, lived experience, and how effective respiratory muscle training can be at reducing it.
Yeah, and I guess that's where telehealth will play a role as well. You
Yep.
can monitor compliance and things like that.
Yep. Well,
Um,
you guys have that fancy, nice BreathLink
we
device.
do now. There, Powerbreathe
Which
have launched a smart adapter and will
yeah,
be hopefully launching a review platform. So
Yep.
yeah, so we've had a few questions, and if we aren't able to answer all of them, then I can go
Oh,
through.
I see him here.
We can
Oh,
always, yeah. So the first, somebody's written, how does incentive spirometry differ from IMT?
that's a great question. So they are different. So on a couple different ways. The main big difference is these devices impose resistance to breathing, right? So there's resistance. We didn't get into specifics looking at tapered flow or threshold-based resistance. That kind of even gets beyond the scope of this kind of intro course. But there's going to be a resistance to breathing, which will impose the demands. It's like putting weights on a barbell or a dumbbell to the breathing muscles. Okay. Incentive spirometry is there's no resistance. So the potential for adaptations are very low. It's analogous, I'd say, respiratory muscle training is like training with weights, right? Versus incentive spirometry is like doing active range of motion, right? There's no resistance there, right? I'm just kind of moving my arms freely. Now, and they're also intended for different things. Incentive spirometry is really more for lung recruitment and to prevent atelectasis, maybe even a little bit of prophylactic airway clearance, right, to kind of keep the lungs inflated. So their intentions are very different as well too. So one again, imposing resistance by providing pressure resistance, and the other incentive spirometry is encourage ventilation in the lungs. So they're a little bit different. And there's actually been studies that have looked at do we see improvements in respiratory muscle performance markers like MIP following incentive spirometry, and not surprisingly, there isn't because there's no resistance.
Mm-hmm. Yeah, I thought that's often a thing that people ask about, isn't it? The kind of difference between spirometry and IMT. Somebody's asked if there's any concern about DOMS.
So that's a great question. Who put that in there? I saw that. That's actually a fantastic question.
Mm-hmm.
Prashna, great question. So there are, I wouldn't say necessarily DOMs. There are some concerns for discomfort at resistances, especially over 60. And that's mainly because as resistance to breathe, and there's like a paper that came out. I just read this like last week. I'm always reading this is like my passion, but which is not this is not surprising. We've known this for many years that we get as again the work of breathing increases. Remember looking at that plot, which is looking at exercise intensity. We can also track it as resistance to breathing increases, which is this paper recently did. We see higher degree of scaling and neck muscle contributions, which can cause a little strain to the neck. So it can be a little bit uncomfortable at higher resistances. So I wouldn't necessarily say DOMs per se, but there is a concern in higher resistances, especially if you start seeing like a ton of recruitment in the neck, like a lot, then it can be uncomfortable for patients. So and typically at resistances beyond like 60% of NIP, we start seeing that to kick in.
Mm-hmm.
Great question.
Somebody has said that they work in acute care and they use respiratory muscle training in an inpatient population. And they were looking for a suggestion of a mobile RMT assessment tool to measure MIP and MEP.
I mean, there's a ton out there. Powerbreathe has. I mean, they're all manometers. They're all in my office now. I used to keep a bunch of them handy here, but they're pretty handy. They're small little devices. I mean, all the ones in the market, even Powerbreathe as well too, are handheld, and they you can use adapters as well too to connect. I've seen even like studies that have used inline like connected to like a tray to assess as well too. So they're using inpatient for sure.
Yeah. Yeah. Somebody has asked, and you did briefly talk about contraindications, but they've asked about how long after an MI can you start inspiratory muscle training?
Yeah, it kind of depends. I'd say at least when they start cardiac rehab, so once they have clearance from cardiology to resume exercise, they can resume training. There are some studies. We have a group here that we presented at AHA looking at post cardiac surgery. So they weren't MI. We've seen that earlier, but for post MI, usually resumption of exercise is when they're cleared for that, they could start training.
Mm-hmm. Jean Gonzalez has said, and I know there is a lot of evidence for this. Is there any improvement with respiratory muscle training on patients with severe sorry,
Scoliosis, yeah.
scoliosis and adults with asthma, which I think there's a lot of papers, but you can probably say a little bit.
Yeah, yeah, there definitely is, and then as well for exercise-induced asthma too. So not only, again, like those conditions may not see necessarily impairments in performance per se, maybe in very severe scoliosis in terms of reductions in strength performance.
Mhm.
But what I didn't mention is sometimes training, even though we often look for patients with weakness, sometimes training does just improve dyspnea independent of improvements in performance. We're not exactly sure some of the mechanisms for that. Maybe it's just improved tolerance to high loads of high loaded breathing. What's also kind of cool, there's been some recent work looking at inspiratory muscle warm-ups. So training at a low resistance, like 10% of MIP, and using that as a primer to facilitate blood flow to the lungs, to the breathing muscles, which may help tolerate exercise a little bit better in patients with exercise-induced asthma. We also think there may be some stuff kind of going on with um, airway sensitivity to a certain degree with like the pressure that goes through the lungs, remodeling possibly, but there is some work looking at inspiratory muscle warm-ups as a way to improve exercise tolerance and symptoms in patients with asthma, specifically exercise-induced asthma. So to answer your question, yes, there's a place for it.
Yeah. As I say, we've had a lot of questions, so if we can't get through them, I will go through them after and try and get back to people. There is, I mean, I can group a couple. Some people are asking sort of how long, and we talked about this with the MI, how long after an acute exacerbation of COPD or cardiac surgery can you commence respiratory muscle training?
Yeah, so cardiac surgery again, it's usually going to be the same kind of time frame. So for the big thing is this sternal wound healing. So we're looking at like 6 to 8 weeks. But have been some studies that have trialed it in 4 weeks. So that's again, it kind of depends on the facility. And
Hmm.
then COPD exacerbation, same thing. Once they're clear and ready to resume pulmonary rehab, that's when they can start training.
Hmm. I'm just looking down. There's a few people that I sort of know of as well, and some people are talking about breathing pattern disorder, which I know is
Yeah.
often a concern when you're testing or training people with RMT. So is there anything that you can sort of discuss in terms of how we don't or yeah, how you minimize making a breathing pattern disorder worse with
Yeah.
RMT and what you should put in place to stop that from happening?
Yeah, I don't think RMT is going to make a breathing pattern disorder, and breathing pattern disorder is also like can be a bit of a nebulous diagnosis too, because like depending on what if you're using objective assessments for it, and I think they're like breathing pattern disorders are most meaningful assessed during exercise because that's really where the pattern of breathing is going to matter the most because we talked about this normal changes that should occur of tidal volume and frequency of breathing. Um, but with anything, as with testing, is making sure you're giving patients appropriate cueing, appropriate rest between trials, a minute rest between trials, and then emphasizing where you want them to be breathing from, chest and abdomen. But I don't know of any. I don't know of any papers that have suggested that it worsens breathing pattern disorders. And in fact, it may may improvement. There's often something to be said too about like you know we see this sometimes even with like muscle issues, like doing a little bit of like loading sometimes the muscles can help kind of relax people. And I wouldn't be, I don't know if this has been published, but I would be interested to see if that works, if that like even helps just psychologically with some of those conditions too. So, but
Mm.
to my knowledge, I don't know of any. If you follow protocols, if you give appropriate instructions and cueing, well, again, like the familiarization period is super important that it would worsen the breathing pattern disorder.
Hmm. I know some of the clinicians that we work with that treat breathing pattern disorder, like you've said, have said ideally you would see a patient do a testing and a training session in practice
Yeah.
so they know what they're doing and then they go away and they can continue it at home. If I know reality that doesn't always work. Are you okay for a few more questions, Rich? Or
Sure, yeah.
yeah.
Oh, Proxima, yeah, the threshold trainers. Yeah. Yeah, there's a ton of out there. Yeah, they missed their time in the market. Is there a way to indirectly train muscle we address? Is there a way to indirectly train for respiratory muscle? Should we directly address? I don't know what that means.
Yeah, I'm not
Uh,
familiar.
I mean, again, like as you exercise, those muscles get like stimulated and loaded, but the main issue is some patients just can't do it. Da, 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 da.
Mm. Um, Somebody is asked if you can explain the difference between the MIP and peak pressure. I mean, that's a specific power breathe question, so maybe I can always answer
Yeah,
that at a later
yeah.
stage.
To
And
my knowledge, I think they're the same,
they're yeah, pretty
pretty
similar.
much the same thing. Yeah.
Yeah, the MIP and the strength test and almost equivocal. It's a baseline measure.
Yeah.
Um,
Oh,
and
Mindy. So the Power Breathe devices, the handhold ones, they if you look in their booklet, they actually do correspond to a pressure threshold, and
mhm,
I think it's like 15, 35, 55, depending on the
yeah,
device. So they actually do correspond to a pressure threshold.
yeah, and the thresh, yeah, because you've got different levels, so yeah,
Yep.
people can get information on that for sure. Um, I don't know if there's many that are. There was one, somebody wrote, when looking to develop respiratory muscle strength through utilizing 30 breaths at 50 to 60, I assume they mean MIP, could this protocol be developed in the same way traditional strength training would be by moving up towards 90%?
Yeah, I would not do that.
Yeah.
Again, like when you
Right.
start going beyond 60 and certainly above 80% of MIP, it is really uncomfortable
Mm,
for patients. Now, there are some caveats to that. There are some, my colleagues in speech do some more ballistic like training for expiration, for like cough function. So there are some indications, but um, generally for most people, our loads are going to typically be around at most 60, just because again the discomfort that can happen beyond 60%.
mm-hmm.
But if you do, just make sure you're communicating that for
Stage
athletes.
for
I mean,
athletes.
because but remember, it's also going to be normalized to the patient's performance. That's why so while it may be like still 50, 60%, I've had some athletes with a MIP that I've tested like 150, 175.
Mm,
So again, like it's you're gonna be training at like 90 like centimeters of water. So it is a pretty high degree of resistance.
yeah. Somebody's talked about expiratory muscle strength training, which is another topic that we will cover under the Better Breathing Institute. So that will come up. And then there was just a question about IMT and recovery of diaphragm paralysis. I think there's a lot of papers from Brazil. I know some um, physiotherapists that we've kind of worked with have looked into that. I don't know if you have anyone you recommend as in a paper, Rich, or
Yeah, I do actually have a colleague, Annie Palermo. She's down in Australia. I should know what institute she was just in my apartment a few months ago with my good friend Aubrey. We were both went to Miami. All three of us went to Miami for PT school. Um, but she looks at this specifically spinal cord injury. And yeah, there are absolute indications for patients with paralysis
Mhm.
or high cervical lesions. Now, what you'll often get is, again, think of breathing beyond just the diaphragm, right? Because there's other muscles involved. And what often happens is that there is lysis, right? If there's damage to the nerve and it's not, you may want to be focusing on improving strength in the contralateral, because again, there's bilateral phrenic nerves, maybe the one that's preserved, or intercostal or scaling muscles to preserve breathing with the diaphragm being lost if there is paralysis. So the diaphragm might not recover because there's the nerve is severed or severely damaged. Um, you may be strengthening the other hemidiaphragm and then the surrounding quote unquote accessory muscles of breathing, which is what they're going to have to use because that's kind of what they've got left over. But there are indications for it. And in many use cases, because again, breathing is the number one cause of disability, morbidity, and mortality in patients with neurological conditions, such as spinal cord injury, stroke, Parkinson's, ALS. There's indications for it.
Mm. I think probably in the interest of time, we've run over a little bit. We've answered most of the questions, and I can always go through and follow up with anything that we haven't answered. But I just wanted to thank you, Rich,
Of
for your
course.
wonderful webinar this morning. It was really insightful. I think people seem to have enjoyed it. So thank you for your time. We will next be hosting a webinar with Professor Bernie Bissett, who's going to be
Oh,
taking
nice.
us through the journey from before, during, and after ICU. So we will send information out about that webinar in due course. But I hope
Fantastic.
everyone has a good day or afternoon or evening, wherever they are. Um, and and yeah, thank you very much, Rich.
Take care, everybody. And
Thank
again,
you.
feel free to reach out. I'm always active on social medias or to reach out me onto me on LinkedIn or shoot me an email. But thank you so much for your time and the power of breathe. And you guys have a great weekend.
Thank you. Bye. Bye.